Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. To JVRD's Author Forum and our podcast today with one of our superb pediatric specialists, Dr. Michael Shapiro from Chicago, Illinois. Dr. Shapiro is going to talk us through a recent manuscript on aggressive onset of a progressive fever phenotype in a child with novel mutations in LRP5 and TSPAN12. Michael, welcome.
Thank you very much. Great to see you, Tim.
Great to see you. So, you have such an amazing, pediatric practice, and it allows you to see things that many of us don't see within our career. But I think this paper was very important, not just for the report, but also because of how it impacts sort of pediatric screening for people that aren't pediatric specialists. So could you tell me a little bit about what you saw with this child, what was unique, and what you were thinking initially?
So this fellow came to me at 3 years old, and from a pediatric ophthalmologist who basically was scared out of his mind, said, "Michael, this kid came in for strabismus, and I looked at the back of his eye. I think this eye is lost. I don't think there's a chance. I don't know what it is. I think there's no chance." And I looked at it, and it was pretty horrible. There was blood covering the macula in the right eye and the left eye. There's all kinds of loss of blood vessels, hemorrhages, lipid, neovascularization. And this was many years ago. This is actually, I see the kid now, he's 20 years old.
I love that.
And so the first thing to do is get rid of the ischemic areas. I mean, it's pretty straight. But before that, we just scheduled an EUA, brought him to the operating room, and did a fluorescein, and there was massive non-perfusion in the periphery.
And so, Michael, you've got this child, 3 years old, referral, bilateral disease, no prior history that we're aware of, and you're in the OR, you see what you see. Are you already thinking diagnostically in a differential diagnosis? What's your thought when you're seeing this child in the OR?
So I think at that time, I really thought maybe this was some kind of weird coats, because there was a lot of hemorrhage and telangiectasia and irregularity to the border between the vascular and avascular retina. And I don't think that I initially thought about fever. I thought it was sort of in the back of my mind, but my first thought with this is some kind of bilateral Coates, syndromic Coates. And yeah.
We talk a little bit about Coates plus and, that overlap between fever with, is it ROP for the preemies, or is it really different from ROP? Is it Coates or Coates plus? I find those really complex decisions. So what guided you initially in managing the child?
Well, so there's the ischemia. So there's the diagnosis, and the ischemia needs to be treated. I mean, I think that when I was trained, we were still reading like the BRVO clinical trials, which said, well, maybe we should treat the ischemia. Maybe we should wait till it's really a lot of ischemia. Maybe we should count the disc diameters. But I think in pediatric cases, if you see ischemia, it is going to lead to complications, and that needs to be ablated. You just need to do laser, and you need to treat ischemia.
And Michael, so when you look, the blood didn't preclude your being able to see the ischemia, and it didn't preclude your being able to treat with laser, correct?
That's correct. So the blood was really posterior, and I wonder what was under the blood, but really I could see blood vessels beyond it.
And so, Michael, one of the things that we've shifted toward, in addition to ablative therapy, is the use of an anti-VEGF. But this was 17 years ago when you saw this child at 3. So Would you do something differently now incorporating anti-VEGF?
This is a really important topic, and I think it's not resolved. And um, in this case, I did. It was a kitchen sink, throw everything, Hail Mary kitchen sink kind of case. So I did laser for the first round, and I did monthly EUAs, which I actually think when you have aggressive disease, you don't want to wait 3 months between EUAs and treatment. You want to make sure that you are getting back on track. This eye is off track and it's going to be blind. And your pediatric ophthalmologist is not a dope. He's right. Most cases like this do badly. So I think monthly exams, and it's the first time I did laser, but the second two, I did laser plus bevacizumab. And so, and then it was a weird thing to do. It was really sort of questionable, but it was, definitely the thing to do, I think.
So that point that you make about not waiting for your follow-up, I think that's a critically important point. And I think when you've got aggressively bad disease, really pulling out all of your treatment options together, where you coupled bevacizumab with laser, I think that's exactly what I would have done. When did you start thinking about genetic testing for this child, and why would that have been important to you?
So I must have been thinking about it. So this is a few years ago. I must have been thinking about FEVR. So I certainly examined the parents immediately. In my notes, I note that the parents are normal. And I did do, and I was looking for fluorescein. On fluorescein, I was looking for FEVR. So it was certainly there. Um, and the parents appeared normal. They appeared completely normal. Um, Recently, since publication, the family has shown up, and I was able to convince them to do wide field fluoresceins, and they essentially look normal. There was actually no telangiectasia. The termini are not, they're not brush border kind of termini. The termini look normal termini. They may be slightly displaced posteriorly. I'm not 100% sure, or they may be perfectly normal. I was shocked. I did not see the findings of autosomal recessive FEVR. I saw nothing.
Interesting. Now, when you did genetic testing, did you test the family or just your patient?
We did this in a free testing program, and so I tested anybody who was willing to be. I think the child got tested, and later on I did test the parents, and it does turn out that this is the LPR5, TSPAN12, and I don't remember if the father has which and the mother has which, but one each of them have one of the mutations, and the child has the compound or the combined heterozygous form of this, and it's shocking. I mean, the parents they have less than an autosomal recessive FEVR case.
That's so interesting, right? So if you weren't genetic testing, you would miss the interest here. But the fact that this child has both, do you feel that's a major contributor to, an aggressive phenotype?
Yeah, I think it's super aggressive. So I have some patients with actually autosomal dominant FEVR from frizzled 4, and they're homozygous. And the homozygous is very severe. But I would say this is very close to a homozygous autosomal dominant. I mean, this is really pretty horrible looking.
Right. So if looking back now, I think that my take home would be, think a broad differential. Examination under anesthesia is critical. Think about fluorescein to look at the vasculature, aggressive treatment for the ischemia, and then genetic testing becoming integral in terms of looking at the child and the family.
Yeah, and I also added vitrectomy here because strangely he had disc neovascularization. Have you ever seen disc neovascularization in FEVR or
No,
coats? I think I saw it in coats once or twice.
I've seen it in coats.
Yeah, but I've never actually seen it in FEVR where you have neo off the disc.
So, when I look at this, I think you had an excellent outcome for an incredibly complex case. So your pediatric ophthalmologist has to love you.
He
But
does.
right. So, but isn't it interesting? How long do you think this was present before it was really recognized? So, do you think this is an at-birth anomaly?
Great question. That is super great question. I think this is actually a progressive obliterative component. And I think one of the things that's interesting that if you sort of like a Coates plus, right? More like an incontinentia pigmenti, than your standard FEVR. So, I'm not including the inflammatory component, but just the idea that the morphology is not a smooth border, right? So if you look at the morphology of this case, you don't see a defect in angiogenesis with a smooth border that stops, some distance from the closest large vessel. What you see here is you see a very irregular border with capillary dropout. That is, the kid does have, and makes me very nervous, some fine capillary progressive disease at 20 years old. And I find many of my Coates patients, if you watch them 10 years, reaccumulate the places that had lacy vasculature. Some of them progress and get aneurysms, and they can actually go on and have trouble.
Well, I know you and I emphasize how important it is to have extended follow-up for these kids into their adulthood. So I think this is a great case, and you handled it beautifully. The genetics are fascinating. So I'd like to thank Dr. Shapiro from Retina Consultants in Chicago for joining us today for the Authors Podcast Forum. Thank you, Michael.
It's been my pleasure. Thank you, Tim.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts, Google Podcasts, and Spotify. Visit www.asrs.org/JVRD Forum on the ASRS website to learn more. See you soon.